So my name is Raj Govindraj, and I'm a basic science faculty. I'm an associate professor in the division of pharmaceutics. I primarily do research. I work on cancer. My interests are in finding new therapeutics for pancreatic cancer patients. So we look at novel combination drugs, microRNAs, and other new kind of therapeutics, for improving survival in pancreatic cancer patients. So if anyone is interested, to learn about some lab techniques, or know a little bit more about cancer research, you can always approach me. You can email me. We can find some opportunities to work in my lab. Okay, but today, we are going to go over formulations for anti-anginals, and Dr. Blake gave a very nice introduction, talking about ischemic heart disease, risk factors, and so on. So let's look at some formulations for nitroglycerin and other nitrates, beta blockers, and calcium channel blockers, which are commonly used to treat these conditions. Okay. To understand formulations, we need to really go over some basic pK aspects. Okay, if you remember this curve, which is concentration time profile curve, can anyone tell me what kind of administration of drug is this? Is this an oral administration profile or an IV? It's an oral administration profile. You can see that the plasma concentration of the drug increasing, right? So why is it increasing? Let's try to make it a little bit interactive here. Why the drug is or the plasma concentration is going up? Because of absorption. So the drug is getting absorbed. Where exactly absorption is finished here? Can you point your finger at the graph and show me like where absorption stops? Where? At the peak? How many of you say at the peak? No. So where absorption begins and where absorption ends? So it's not at the peak. Right? So absorption starts right here, right? Where it ends? At the end of the curve right here? Are you sure? So the absorption could be complete for many drugs very early on, right? It doesn't have to go here. So why the curve, why the drug is accumulating? So the curve is going up because the drug is accumulating more and more in the body, right? That's because the total absorption or the buildup is far more than the elimination of the drug. So that's why it's increasing. At the peak, what you have is the amount of drug absorbed and the amount of drug eliminated. They are balanced, right? And in here, what's happening is the amount of drug absorbed is going down. The elimination rate is far exceeding the absorption rate. So we can't really tell, where exactly absorption is ending here. Okay. All right. So you have Cmax. Okay. Can you figure out half-life from this graph? Right. So half-life is the time taken for half of the amount of the drug. I say amount of the drug, right? To get eliminated from the body, right? So what you have is a concentration here. It's the elimination phase, right? Concentration is proportional to the amount. So you can sort of find, from what concentration it becomes half, and that time corresponds to half-life, right? So why are these important, right? So when you administer a drug, you have a profile like that. Can you really tell where is the onset of action of the drug from this curve? Can you tell or you cannot? So you have a buildup, right? So where do you think it's most likely, the peak effects of a drug is likely to happen? At Cmax, right? So that kind of you can predict that. But can you really tell, like, when a drug starts to act? Is it earlier than Cmax or later than Cmax? It's earlier than Cmax, right? But you really can't point at what time. It really depends on the drug, right? Some have an early onset, so it depends on the therapeutic index, right? So have you seen these kind of abbreviations before? I'm sure you have seen it, right? So what IR stands for? Immediate release, sustained release, timed release. All these are for extended release. Okay, CR for controlled release, right? So later today we'll see a formulation, controlled release formulation for a calcium channel blocker, and sometimes this is also called as CD or controlled delivery. Okay, all right. So why it is important? We need to understand based on the PK profile. When is the onset of the drug, and how long the drug is going to act, which is nothing but the duration of action, right? Can you even tell that from here? No, not really from the PK curve, but you can sort of predict. Okay. So if you look at this is the therapeutic range at which you have an action. In this case, you have a pretty good onset here, and that prolongs. The duration stays up until here, and beyond this point, there's not much or drug in the body, to produce the desired action. So you ideally want to stay within this region. Okay. However, what you have is excess drug in the body, right? So this is somewhat an unwanted exposure, right? So whenever you give an immediate release formulation, any tablet or any ordinary formulation, right? So you have a profile like that, but what you need is really, this boxed region here, but you have excess drug here, right? So ideally what you need, an exposure profile, something like that, the flatter the better. Okay. So how can you achieve that? Right? So you can either administer, at frequent intervals, you can alter the dose, right? Or you can change the formulation from immediate release to a delayed release or an extended release. So what you can modify is your plasma time concentration profile to become more and more flatter. In other words, you can actually extend the period of action. You can make it more flatter, so that's going to increase the duration of action. From here to here you have a longer duration of action. Okay, that's the basis for extended release formulations. Okay, so when you think of formulations, there are multiple ways you can define formulations. Say for example, gaseous formulations, anesthetics, or liquid formulations like fluids or semi-solids, ointments, and so on. So that's one kind of formulation. Another one is based on the route of administration, intravenous, intramuscular, subcutaneous, and so on. So, but what we are going to deal here is formulation based on the release mechanics of drugs. Okay. So the idea is you can modify how the drug is released. Okay. By that you can modify absorption, and you can modify the PK profile. Okay. You can either extend or even shorten, but in our case we are going to see how we can extend the duration of action. Okay. So if a chemical entity, like a drug, makes really more sense, only when it is properly formulated and administered. Okay. So anything that releases immediately, that's an IR, immediate release formulation. Anything you modify, it's a modified release. So if you delay the release pattern, it's called delayed release, and if you prolong the release pattern, it's extended release. And if you want to release only in a certain tissue, In our case, we are interested, in cancer drugs. We want to release the drug only in cancer tissue, not in normal tissues. So that's a targeted release, and so on. So the basic difference between immediate release and modified release, you should know, and let's go over one by one. Okay. All right. So the first class of drugs, nitrates. We'll start with nitroglycerin. Okay. Let's look at it. It's the structure. It has a glycerol backbone and 3 nitrates, right? So what is it special about it? Nitrates. Okay. It's a very liposoluble drug. If you consider, a soap bubble colliding with soap bubble, it just simply diffuses into membranes. Okay. So because of that, it just easily passes through the gastrointestinal tract, and then it gets into liver. And it's metabolized rapidly. It's a very high, extensive metabolism in liver. So because of that, you have very little oral bioavailability. If you look at the bioavailability of nitroglycerin, it's less than 1%. So most of the drug gets chewed up in liver, right? So it makes sense to administer nitroglycerin not as an immediate release tablet form, right? Because you will have only 1% of the drug available, right? So remember, nitroglycerin has a very high first pass metabolism. So that's why we modify the route of administration, okay, to increase bioavailability. So if you administer sublingual, okay, lingua for tongue, below the tongue, okay, so the drug is going to get into systemic circulation. So it's going to bypass liver. Okay, so that increases bioavailability to about 40%. Okay, likewise, if you use it as an ointment, again, directly, the drug is going to get into systemic circulation. So that's going to increase your bioavailability even more. Okay, also if you look at clearance, it has a large clearance, large volume of distribution. Okay, half-life of 0.05 hours, in other words, 3 minutes. Okay, very short half-life. Okay, 1 to 4 minutes. So you can see that this drug, highly liposoluble, highly metabolized, very poor bioavailability. Okay, because of high first pass metabolism, and you can increase bioavailability by changing the route of administration. Okay, so what kind of formulations are available? Based on this PK. We have certain formulations, in case of acute treatment of angina, there are formulations, the most common one used is the sublingual tablet, okay, under the tongue tablet. And you can also use chewable capsule or what is called as a mouth spray or translingual spray. And these are not very popular. They are expensive, particularly the mouth spray, and insurance doesn't cover it. So sublingual tablets are the most common form. And you can also use it as an IV infusion. Again, you don't have to worry about first pass metabolism when you use it as an IV infusion. It's very essential for acute myocardial infarction. And then, you can also use other formulations like controlled release capsules, or skin patches and ointments and so on. Okay? Any questions up until this point? All right, so let's look at sublingual tablet. Okay? So these are these come at different strengths, but what I learned is the only common strength used in pharmacies in Ohio is 0.4 mg tablets. Okay, the tablets are printed with the letter N on one side, right here, and then the strength in milligrams right here. It says 4 milligrams. Okay, so the way they administer it is they have to sit down and take a tablet, and they have to place it below the tongue. Okay, and if they ask, can I chew it or can I swallow it? Obviously, they shouldn't do that, because then it becomes an oral formulation and it'll undergo first pass metabolism and they'll lose it. So they have to leave it here. It might create a little burning sensation. That's good because of the local vasodilation effect. That means the drug is working. Okay, and you can expect onset. So now here you can see what's the onset. It's a minute to 3 minutes. Okay, Is it like close to half-life? Yes, but it's half-life doesn't quite say the onset or anything. And then the maximum effect is seen at 5 minutes. Perhaps the Cmax hits at this. If you look at the profile here, say here. So you have Cmax for, so in this case, you have nitroglycerin taken as 2 tablets, each as 0.3 mg, and here, 1 tablet at 0.6 mg. Look at the Cmax. Okay, it's 2.3 nanograms per mil. It needs that many nanograms, for Cmax, and Tmax. It takes about 6 minutes or 7 minutes in the case of a single tablet. So 6 or 7 minutes is where the Tmax is, right? So no wonder you have a maximum effect at about 5 minutes, and that's why for angina, they usually take 1 nitroglycerin tablet, and if they don't see relief, they go for the second one after 5 minutes, okay? And so that's because the maximum effect you would expect at 5 minutes. If nothing happens, you go for another dose, all right? All right, so how long is the duration of nitroglycerin? Do you know? What is the duration of action of nitroglycerin, sublingual tablet? About 45 minutes, 30 minutes to 60 minutes. So if you look at the T-half, okay, half-life, it's about, what, 3 minutes, 2.8 or 2.6, give or take 3 minutes, okay? So how long it's going to stay in the body, your nitroglycerin? How many half-lives? 5 or 6 half-lives, right? Right, in the first half-life you have only 50% of the drug, right? In the second half-life you have only 25% of the drug left in the body. So to clear more than 90% you need 5 or 6 half-lives. So 3 times 6, about 18-20 minutes, right? So 30 minutes is a conservative number, and then an hour is a very lenient number. So the duration is about 45 minutes, so that's the maximum duration you can expect for nitroglycerin, okay? And it's sometimes used for prophylactic use, so treatment for anginal attacks, but you can use it even to prevent it. If they start engaging in some strenuous physical activities, they can go take the tablet 5 to 10 minutes prior to starting a physical activity, because why this 5 to 10 minutes? Again, think about the onset, okay? So for the effect to take place, it takes about a minute or 3, okay? All right, so here is it. So the sublingual tablets, there's a rapid onset, and the duration is brief. It's about 30 to 60 minutes. Okay, the same thing for translingual spray. Okay, what is a spray? Even though it's not so popular, it's good to understand. So the spray, it produces a mist of the drug where it's in aerosolic form, so increase the surface area, so increases absorption. So the idea is to have a rapid onset. Okay. However, it's cost prohibitive. So for each spray, this formulation releases 400 micrograms. Okay, and a bottle can go up until 60 to 200 meter spray. And again, it's great to use before physical activities. Okay, and sometimes these bottles need to be primed, which is nothing but there could be some dead space, and you have to remove the space to consistently deliver the drug. And again, like sublingual tablets, one has to sit down before applying the spray. And again, it's sprayed in the mouth region, entire mouth region, and it can also go under the tongue. Okay, so usually they do 1 to 2 sprays and then they close the mouth. Again, you don't want to rinse your mouth or avoid eating or spitting. Just have to stay there for the drug to enter through the buccal vessels. Okay. All right, so then the IV formulation, in this case we have glass vials containing nitroglycerin. This is a concentrated vial. again, nitroglycerin is very reactive, right? So it is important what kind of container it's placed in. So in this case, it's a glass well. Even the tubings, you should be very careful. Plastic or PVC could react with nitroglycerin, right? So you have to use special coated tubings. And here, the concentration of this vial is 50 mg per 10 ml, okay, in milligrams, okay. So one thing you have to remember is, we shouldn't give nitroglycerin in a concentrated form as such in IV. You have to always dilute it, okay. It's always in micrograms we give them, okay. And when you dilute 25 mg in 250 ml, sometimes it comes in a diluted form. In this case, this is 100 microgram per ml, okay. And there's a way to calculate, how your final concentration here. What is the type of volume and how much nitroglycerin from the vial you have to draw and bring it to a final concentration, okay. So you can see that the concentration, sort of increases with the concentration of the drug in the vial, okay. Again, in practice, this is really great for ER situations, right, where the great thing about IV is, it directly gets into the systemic circulation, so your onset is right away, right. It's a very rapid onset, and also, you need to monitor, when you are in ER and giving nitroglycerin IV, you can also monitor, like heart rate, blood pressure, and so you can actually titrate the effect, okay. Again, there is an initial dilution you use, and then you maintain. So you go slow and increase your dose, with time. Again, you can follow, this 5 microgram per minute every 3 to 5 minutes. You can increase in that increment, okay, and you can go to a maximum dose of up to 400 microgram per minute. Okay, you can even go beyond that, but there are not many studies that suggest that beyond that, what will happen. It's not clear. So at least, for now, you remember that's the maximum dose. Okay, any questions on IV nitroglycerin? All right, so ointments and patches, these are again, topical application. Ointment comes in a strength of 2%. Okay, so what you do is, you actually have a strip like that. You measure a certain amount of ointment here and apply it in the upper part of the body. Usually, above the elbows and knees, where the skin is really not that thick, and you avoid regions where there is excess hairs, and you just apply it, and you can even rotate. So you can start with applying on your right arm, right chest, left arm, and so on. So because it's going to cause some reddening and some pain, and so it's good to rotate. Also, you have heard of the nitrate-free interval. You want the metabolic enzymes of that kind of break down nitroglycerin to its really active product, which is nitric oxide. You want them to bounce back, so you don't want tolerance to occur. So it's good to rotate. So also, you should make sure that when you apply it during the daytime, you remove it during the nighttime, so that you don't want the drug to be present all the time. That can increase tolerance too. So the same thing with patches. Again, there are patches that comes in multiple strengths. Each release a certain amount of drug per hour. Again, these are worn once a day. Okay. During the daytime, and again you can remove in the nighttime, or the other way around is also fine. As long as there are nitrate-free intervals, these should work fine. And again, choose a spot, upper body or upper arms, and different area each day. Okay, so these two are topical preparations, the patches and ointments. Okay, so any questions on nitrate formulations or nitroglycerin formulations? Okay. So if not, we'll move on to the second class of nitrates, isosorbide, mono and dinitrate. Okay. So if you look at nitroglycerin, okay, so what we finished now. So if you look at the either the sublingual tablet or translingual spray. So what you have is a rapid onset. The onset is within 1 to 3 minutes, But the duration, if you look at it, it's brief. It's only 30 to 60 minutes. Okay. So after nitroglycerin was used, it was started in 1847. That's when nitroglycerin was first used. About 100 years later, Swedish chemists came up with another molecule based on the structure of nitroglycerin. They did a lot of screening and chemistry and came up with isosorbide monohydrate and mononitrate and dinitrate. You have two nitrates here, and here you have one. So if you look at the onset and duration, so these, they have a slow onset. If you look at the onset, it's not like nitroglycerin. It takes some time. It takes about 30 to 60 minutes to exit an action. But the greatest asset of isosorbide nitrates is the duration. You can have a longer duration of action. Okay, but the problem is you have slow onset. For treating angina, you would require, ideally what you would require is a rapid onset, but a prolonged duration, right? So you need a combination of those. So again, sublingual tablets of isosorbide dinitrate, it fulfills that, both these properties. You have a rapid onset and long duration. Okay. All right. So if you look at isosorbide mononitrate and dinitrate, okay, they come in different strengths. Okay, and you also have so the mononitrate, the dinitrate has to get metabolized to mononitrate, and again this is the active form. So it takes some time. The onset is relatively a little slow here for tablets, for dinitrates, because it has to get metabolized to mononitrate. Okay, but in both cases we have an extended release formulation. Okay, so that kind of reduces. So normally mononitrate is used twice daily, and dinitrate 3 times a day. But the development of SR formulation allows once daily administration. Okay, and if you think about just the immediate release forms, okay, since if you're giving it as a tablet, it's going to take some time for onset, right? So it's but if you make it an immediate release to a sustained release, okay, so that's going to change the release pattern. It's going to extend the duration. But again, there's no rapid onset, so it's not really, sustained release tablets are not really useful for acute anginal attacks. Okay, it can help in say preventing a day-long angina. For if you want longer duration, it's great. But if you want a rapid onset, the sustained release tablets are not that great. Okay, so you have to choose accordingly. All right, so questions on isosorbides. Okay, so remember, the greatest asset is the longer duration, and if you use it in a sublingual form, you can also get rapid onset. Okay, so how are these drugs, nitrates, get metabolized? Okay, if you look at nitroglycerin, we already saw that high first pass metabolism. So actually there's a very high amount of liver metabolism, whereas isosorbides, they excreted through kidneys. Okay, and so if you think about, say, even choosing between these two, in renal disorder patients and liver disorder patients, think about it. Which one would you choose, say, in case of severe liver disorders? Isosorbides or nitroglycerin? Somebody with severe, so you choose isosorbides, right? Because it's mostly renally eliminated. Okay, nitroglycerin, liver metabolism is very important. Okay, all right. So the percent excretion through kidneys is given here. So for IV patch and ointment, there's only 22%. So there's very less percentage for nitroglycerins. But if you look at isosorbides, 80 to 90% is eliminated primarily through liver. Okay. All right, so the way it breaks down nitroglycerin, again, it breaks down to simpler forms like glycerol and organic nitrate. Okay, in case of isosorbides, they get glucurinated in liver. Even though they are eliminated by kidneys, it's the glucuronide form. The glucuronidation still takes place in liver, so you still have to consider that. Okay, so one thing you have to consider when you administer nitrates is the drug interactions. Okay, so when it's given along, you cannot give it along with phosphodiesterase inhibitors like Viagra and so on, because they are known to decrease blood pressure, increase cardiac output. So it could precipitate acute hypertension when you give it with nitrates. So if somebody is engaged in these activities, in this case sexual activity, you have to separate these drugs. If they have to take both, they have to at least separate these drugs for 24 to 48 hours. Likewise, you can't combine nitrates with heparin, because nitrates can reduce the anticoagulant effect of heparin. And you have to be very careful when you're combining nitrates with other antihypertensives also. All right, so I'm going to skip the nitroglycerin tolerance part because you've heard it already. Let me see if I can switch to beta blockers. All right, so the next group of drugs, beta blockers. Again, I'm just going to talk about the PK aspect and formulation aspect of it. Okay, and look at the drugs here. I've chose carvedilol, or Coreg, metoprolol, toprol, and then atenolol. Okay, so let's look at this PK chart, for a minute here. Look at it carefully, and then understand what's different between these drugs, and then we'll go over some questions. Okay. Okay, so which one of these has a very short half-life, or the shortest half-life among these? Metoprolol, right? So how much is it? It's 3 to 4 hours. Okay, and compared to metoprolol, carvedilol, Coreg has about 7 to 10 hours. Even this is about 7 hours, atenolol, right? So which one has to be administered more frequently? Again, metoprolol, right? An immediate release formulation, because it has a short half-life. Okay. What about volume of distribution? Which one has the smallest volume of distribution? It's again metoprolol, right? So if you look at it, it's only 3 to 5 liters per kilogram. Whereas your carvedilol Coreg has a very high volume of distribution, right? So just by looking at half-life and volume of distribution, you know that metoprolol needs to be administered multiple times, right, because of the shorter half-life, whereas you don't have to go that, you don't have to increase the frequency of administration for carvedilol. And again, what's the basic difference between Coreg and toprol? pharmacologically?
Oh,
Selectivity, right? Which one is more selective to heart? And carvedilol, where does it act? At the periphery? Okay, so now look at the absorption, okay? Which one has the highest bioavailability? So we only, I only have it for carvedilol and metoprolol, So all of them are rapidly and completely absorbed, after an oral administration. But you have less bioavailability for carvedilol. Metoprolol, it's about 50%. It's the same for atenolol. I didn't put it here. And if you consider bisoprolol, it's even higher. It's about 90%, right? Okay, so which one needs lesser dose? Based on just looking at bioavailability. Metoprolol, right? Okay, so that's absorption, and then you saw distribution, okay, volume of distribution and half-life. So let's look at metabolism. So, okay, look at metabolism. What do you have for carvedilol? It's glucuronidation and sulfation that happens in liver, right? And also there is a P450 based metabolism. So metoprolol is metabolized by CYP2D6 primarily. Okay, that's the reason, even for the high first pass metabolism. Okay, carvedilol uses both 2D6 and 2C9. Okay, so if you look at liver metabolism here, there's fairly, quite a bit of liver metabolism happening, except for atenolol, it's limited for hepatic. So how much of the drug is excreted through urine? So if you look at carvedilol, Coreg, less than 2% of the drug, okay, unchanged drug, which means the parent drug is excreted through urine. Okay, the primary route of elimination is through feces. So after it gets glucurinated or sulfated, they're thrown into bile and excreted through feces. So now what actually goes through urine is only less than 2%. Okay, and if you look at metoprolol, so again, this 95% is not just parent drug but also metabolites. There's a significant amount of it getting through urine. So if you look at unchanged parent, it's only 5%. Okay, so don't get misled. Okay, this is all total parent and metabolites together. So in this case, with metoprolol and carvedilol, there's about 5% of drug at the most, getting through urine. Okay, the majority is through feces. But if you look at atenolol or bisoprolol, a significant percent, in this case 40% of the parent drug gets out through urine. Okay. So if you have a renally impaired patient and if you want to choose a beta blocker, which one would you choose? So here, there's only 2% of the drug is getting through urine, the majority through feces. And here about 5%, and here about 40%. So which one is good for renally impaired patients? Carvedilol. Okay. So even metoprolol can be used. Okay. This is a little better. Okay, carvedilol. The clinical studies showed even there's not much of a significant problem here. You can either use carvedilol or metoprolol, okay, but not atenolol or bisoprolol. So you always need dose adjustments in those renally impaired patients. Okay, look at the onset of action. Okay, it's roughly about what's the onset for immediate release formulation? It's about an hour. right? So all of these beta blockers, you can see within an hour, little greater than an hour, roughly about an hour, okay? And duration of action. So now here you have a big difference here. If you consider for Coreg, it's 12 hours, okay, for immediate release formulation. For immediate release toprol, it's only 3 to 6 hours because it has a shorter half-life, right? So it makes sense to make an extended release formulation. That's what it's often used, so that you can increase the duration of action to an entire day, 24 hours. Okay, so the way they do it is, right, so there is a delivery system where the primary drug is now packaged in pellet forms. So if you just look at the tablet, you can't find a difference between immediate release and extended release. So they have pellets of different sizes, so that each pellet acts as a delivery system. So they release drug in a certain profile, and then the second pellet goes and release it. So what happens is, instead of that hump in your plasma concentration time profile, it becomes more flatter. Okay, so the release shows an extended pattern. On the peak concentration and trough concentration, if you take, there aren't much of fluctuations. Okay, the fluctuation index is very less. So that's the basis for extended formulation for toprol. It's called toprol XL. Okay, and let's look at one last thing. It's protein binding. Okay, which one has the highest protein binding? Coreg, right? And the lowest, these guys. So what can you think of when it comes to protein binding?
They're taking other drugs that are heavily protein bound.
Perfect, right? So if there is protein displacement or things like that. Say, suppose if they are taking a drug like, say, for example, quinidine, fluoxetine, or paroxetine, okay, which are also metabolized by CYP2D6. Okay, which one you would avoid? So you're co-administering a drug that is heavily metabolized by CYP2D6. Yeah, you want to avoid metoprolol, right? Because that's the major enzyme involved in metoprolol. So there's competition. So metoprolol then becomes less metabolized. It will have a longer duration of action. So there's possibility for drug-drug interaction, right? And you also have to know Caucasians, right? Generally, 1 in 12 patients are poor metabolizers for CYP2D6. So this needs to be titrated, from individual to individual. So, but if you look at protein binding, you have a lot more here. When do you think protein binding can alter? One example you said, administration of other drugs, but also in disease conditions, okay, in extreme liver disorders and in renal disorders, okay, renal failures, they lose protein, right? So that will displace the drug, the amount of bound drug versus unbound drug changes, and that can affect your onset and duration too. So you need to consider all this when you consider beta blockers. All right, so I think you will hear about what's the most effective beta blockers. So in case of heart failure, it's common to use toprol extended release, which comes in the succinate salt form. Okay, so the immediate release comes in tartrate form. The salt has less influence on the PK. It's just the practice, it's just the way it is manufactured. Succinate is used for extended release and tartrate for immediate release. But you can see that for heart failure and severe conditions, it's common to use long-acting form, because all the clinical trials initially supported that. And if you consider immediate release, here is another clinical trial which showed there's not really beneficial effects. There wasn't any increase in survival like that. It's the CBIS-1 trial, which used bisoprolol, and then that was about 2,000 patients, and there was continued by another trial with more number of patients, and that showed some beneficial effect even for the immediate release metoprolol. So at this point, it's not clear which one to use. Maybe Dr. Blake can explain, what you see in practice.
Yes. So I think if you look at the chart, one of the things that will may be confusing, if you look at heart attack prevention, you've got metoprolol tartrate, which is your immediate release form there, and it doesn't look like metoprolol succinate that you can use that for heart attack prevention. So the metoprolol tartrate is the one that was actually studied and showed to prevent heart attacks. There's several studies that have showed that, and the metoprolol succinate has not been studied as extensively in that patient population. But one of the things clinically that we have to take into account is the compliance of the medication. So if you think back to the table that showed you have to potentially do more frequent dosing with the tartrate, those studies dose metoprolol tartrate as frequently as every 6 hours. So how many of you guys think that your patient was taking every 6-hour medication at one time? Probably not. So knowing that, we may use the metoprolol succinate even though it hasn't necessarily been studied or shown to be as beneficial because it hasn't been looked at as the metoprolol tartrate. But in a lot of our patients, if they take something versus not taking something at all because they can't keep up with how frequently they would have to take it, we still will use metoprolol succinate in people that have had a heart attack. Does that make sense? You have to take into account, was it studied, but also the fact of whether they're actually going to be compliant with the medication or not.
Clear?
Yes.
Yeah, a lot of times though you'll still see metoprolol tartrate just twice a day.
Yes.
I think this is the output.
The metoprolol tartrate, yeah. So the studies in the immediate period post-MI, they'll dose it every 6 hours, and then as they get closer to discharge, they'll drop it down to twice a day. So, and you have to look at one other thing you may see, and I don't know what your thoughts are on this. We will see metoprolol succinate sometimes dosed twice a day also, and that's because if you look at the heart rate control of it, you may only get good heart rate control for 16 hours. So sometimes even in heart failure patients, we will dose metoprolol succinate twice a day.
So and you can see that it's clearly based on the condition. So you know fixed regimen you should follow. All right, so one last class of drugs, calcium channel blockers. Again, I want to give you a few minutes just to look at these PK parameters. So which ones are dihydropyridines here? All the blue ones, right? So all the ones with the suffix pine, right? Among that, which one has the highest half-life or the longest half-life? Amlodipine, right? It's 40 hours. It's really long compared to your other points, where you see somewhere from 2 hours, 1 to 2 hours, like nifedipine or nislodipine, okay, and many of them around 8 hours, okay, but nothing like amlodipine. It has a naturally long half-life, right? So that allows once a day dosing, and it's also very cheap, okay. So but generally, what are the problems with dihydropyridines? Okay, they have a pretty rapid action. So because of rapid reduction in blood pressure, what's one common problem associated with that? Hypotension, or it's the reflex tachycardia. Have you heard of that? Right? So the system kicks back and you have tachycardia, and you know, so what you see here, say in this case, so you have verapamil here, which is a phenylalkylamine, okay, that has primarily effects on the heart and these on the peripheral vessels, right? And if you look at diltiazem, that's in between your verapamil and calcium channel blockers, right? So the good thing about diltiazem is, you know, they have less of this reflex tachycardia problem. Okay, so let's look at the half-life again. Amlodipine has a longer half-life, and so if you look at nifedipine, it's only 2 hours, right? So it makes sense to make a long-acting formulation for nifedipine. In fact, you know, there's then formulation nifedipine XL is available, right? So the way they do it is, you know, they use a system called gastrointestinal transit system, or GITS. Okay, so what they do is they have an inert packaging material here, okay, and they have the drug here, and they have a laser punched hole here. So this is a very sophisticated controlled release formulation. So it's given orally. So once it gets into the gastrointestinal tract, you know, water freely gets in, because, you know, this is an osmotically permeable membrane, and this is going to make the inert material swell and push the drug outside, and, you know, by that it allows slow and controlled release. So you can actually play with the release and for nifedipine XL using this formulation, and you can extend the duration of action, and you can, that allows for once a day dosing as well. So, you know, from first order kinetics, it goes into zero order kinetics. So as long as the concentration gradient exists, okay, so the water keeps getting in, you know, this formulation is not affected by gastrointestinal motility or pH or so on, okay. So that makes sense for nifedipine, so you can allow once a day dosing with that. So otherwise, amlodipine and nifedipine, they have pretty comparable PK characteristics. Both have a lot of side effects. Of course, you cannot use them for very severe heart conditions, and also no amlodipine, you can't use it in breastfeeding women, and all of these calcium channel blockers, you know, you have side effects like constipation, dizziness, edema, and so on. Okay. And then you also, if you look at diltiazem, okay, what is the half-life? 7 hours, right? And the bioavailability is pretty decent. So there is also a long-acting form for diltiazem. Okay, so the active metabolite here is diltiazem. And again, the long-acting form of diltiazem helps in once-a-day administration. Okay. Likewise, there's a long-acting form for verapamil also available. Any questions here? I know it's a little too much information, but, you know, you have to think about the immediate release and extended release formulations. What I was trying to do here is try to think about the half-life, okay, and connect it to onset and duration. Why it makes sense to make extended release formulations for certain drugs but not others, okay, based on the PK problem. All right? All right. I'll let Dr. Blas to continue.
Why don't you guys stretch for a second?
Maybe just a quick 5-minute break.
Yeah.
I'm going to stop this. Okay, I'm not going to save it, but just pause it.
All right, you ready? I like the music. Okay, so we're going to start now going through our types of angina and treatment, and hopefully we'll be able to tie in the pharmacology and what you learned about formulations together and interact with each other so I can see what I need to explain further versus what you guys may understand already. So as I had mentioned, and you should have heard in your pre-recordings, the types of angina can be divided into angina with effort and angina at rest. So we're going to start talking about Prismental's angina or variant angina first. And can someone tell me what one of the biggest differences between the Prismental's or variant angina in comparison to chronic stable angina or acute coronary syndromes from your pre-recorded lectures? What was that? It's caused by vasospasm. Very good. So if we look, this slide should look familiar. Variant angina waxes and wanes. It's greatest within the first 6 months, and it's due to coronary artery spasm. So if we look right here in your right coronary artery and kind of take a close-up view of that, the coronary artery is spasming versus having a plaque in there that decreases blood flow, or if you're talking about acute coronary syndrome where the plaque ruptures and you get thrombus formation, and that's what decreases coronary blood flow. So it's spasming of the coronary artery. Most likely to occur at rest and more common in smokers. So when we talk about treatment of variant or Prismental's angina, the focus of our medications is going to be different than if we're talking about plaque blocking the coronary artery or plaque rupture and thrombus formation blocking the coronary artery. So our goals are really simple. It's to decrease the number of times that the artery is spasming and to decrease the risk of MI or death. Risk factor modification, which would mostly be what? If it's a smoker, it's going to be to get them to stop smoking if you can. And usually there's prophylactic treatment for 6 to 12 months unless the patient has an arrhythmia. So if you decrease that blood flow through that coronary artery and they have an arrhythmia, sometimes it can be those fatal arrhythmias like ventricular tachycardia or ventricular fibrillation. We may be less likely to take off the medications after 6 to 12 months, and it'll be with follow-up and seeing how they're doing. So for acute attacks, often these people will present just like an acute coronary syndrome. So they have sometimes complete closure of their coronary artery due to that vasospasm. We'll use sublingual or intravenous nitrates. Why, based on our last lecture, would those be the drugs that we would choose in comparison to something like isosorbide mononitrate or dinitrate? Bioavailability, and what else? They act quickly. Yep. So if you give sublingual nitroglycerin or you give intravenous nitroglycerin based on bypassing that first pass metabolism, they get into your system quickly and they work quickly. Versus something like isosorbide mononitrate or dinitrate, how long are you waiting for those to work? 30, 60 minutes, even longer, right? So if someone's artery is completely spasmed or closed shut and constricted, you want to get something that opens up that artery right away. The other thing to remember as we move forward when we're talking about ischemic heart disease or we're talking about or stable coronary artery disease or talking about acute coronary syndromes, that difference in how those nitroglycerin preparations or isosorbide mononitrate and dinitrate preparations are released is important to remember if a patient's having an acute attack of their stable angina or their acute coronary syndrome, or they're having something that we're trying to kind of maintain them throughout the day to control the spasm or the vasodilation of their coronary arteries. We also will use calcium channel blockers. So what two types of calcium channel blockers do we have? Dihydropyridines and non-dihydropyridines, and it's going to be really important for you guys to understand which ones work peripherally and cause vasodilation, and which ones work at the AV node to block induction through the AV node and maybe cause some vasodilation also. With the calcium channel blockers, if the calcium channel blockers are ineffective or in combination with calcium channel blockers is when we'll use nitrates. So meaning we'll try nitrates. If they need something that's longer acting or they need something to control them through the day, we'll use calcium channel blockers. If the calcium channel blockers are not controlling their pain, we may use something like a longer acting nitrate on top of the calcium channel blockers. And then they'll also have their sublingual nitroglycerin for the acute attacks. When we're talking about calcium channel blockers here, what was one of the biggest differences that you just took away from your lecture just a few minutes ago as far as the preparations? There's ones that are longer acting, like what? What's one that you guys will commonly see prescribed all the time? Amlodipine, correct. And then for those ones that are shorter acting, we have the sustained release preparations that we can use, and those will helpfully control the vasospasm throughout the day. Beta blockers in these patients, and this is probably a point you'll want to star and remember, are not effective and sometimes may lead to more vasoconstriction. They can have unopposed alpha effects, like our metoprolol that works at what receptor? Beta 1. Versus carvedilol that may be alpha and beta. So for these patients with variant or Prismental's angina, we don't recommend beta blockers in most of the patients. Now there's some tricky ones because no patient just comes in and has one problem. So we have patients that may have coronary artery disease, known coronary artery disease, and they have a component of variant or Prismental's angina, and then we just have to weigh the risks and the benefits of those medications for that specific patient. But in most patients, if they have variant Prismental's angina and we've ruled out coronary artery disease, our first-line agents are going to be nitrates and calcium channel blockers. Bless you. As far as calcium channel blockers, this should be something that you already know. There's ones that cause myocardial and vascular vasodilation. These are your dihydropyridines. And then you have your non-dihydropyridines, which are which two? Verapamil and diltiazem, which decrease the force of contraction and decrease conduction through the AV node. For our dihydropyridines versus our non-dihydropyridines, there's some short-acting dihydropyridines. And as you just heard about, and something important to remember, if you cause vasodilation, you can get a what? Reflex tachycardia. And so in some of our patients, when we talk later on about stable angina, we want to make sure that we're controlling their heart rate and we're careful about giving them something like nifedipine, which is short-acting, which there's a short-acting nifedipine and causing a reflex tachycardia. And so we may want to use those longer-acting medications to prevent that reflex tachycardia. And the dihydropyridines have no effect on the AV node. So you often will hear residents when they're, or interns when they're rounding, they'll want to stop some things like amlodipine or nifedipine because of its effect on the heart rate. They don't affect the heart rate. They don't have any effect on the AV node. And so that's often a confusing point if someone's got a low heart rate that they want to stop those medications. It doesn't really make sense because it doesn't affect the AV node. So as far as your calcium channel blockers, the common ones that you'll hear about are mostly amlodipine, nifedipine, and felodipine. In practice, these top two are really the ones that we most commonly see prescribed. Amlodipine, because it's longer acting, patients can take it once a day. Sometimes we'll see it prescribed twice a day. I'm not 100% sure why that is, and usually we'll ask. It doesn't necessarily make sense based on the half-life of the medication. And then nifedipine, actually we'll sometimes see too. It's got a sustained release or an extended release formulation. We used to, a long time ago before I was even practicing, give people sublingual nifedipine. The reason we don't do that anymore is because it causes a profound reflex tachycardia, and increases in their heart rate can make more oxygen demand, and so we don't see that anymore. And then you have your non-dihydropyridines like diltiazem and verapamil. So if you were to take a patient with variant or Prismental's angina and you had them either on something like isosorbide mononitrate or dinitrate and you were not able to control their chest pain and their blood pressure was on the lower side, so say like 100 teens, and their heart rate was in the 90s, which of these two would you choose? Do you want me to repeat that? Okay. So you have a patient that's got various Prismetals angina. So you've got them on isosorbide mononitrate 30 milligrams a day. So your longer acting nitroglycerin preparation. And their blood pressure's in the 100s to 110s. And their heart rate's in the 90s. And you need to add something on to control their chest pain or vasospasm. Which of these groups of medications would you choose? Non-DHPs, why? What's that? Okay. And what about that patient made you choose the non-dihydropyridine? The heart rate was higher and the blood pressure was a little bit lower. So those are the things that you want to think about when you're trying to decide which medication group might be better for the patient, dihydropyridine versus non-dihydropyridine, is to consider the patient's blood pressure, where you want it and what room you got to work with, and then their heart rate and where you want to be and how much room you have to work with. So if you had somebody that had a lower heart rate, 60s, for example, and a higher blood pressure, the DHP or dihydropyridine may be the better one to choose. Does that make sense? Okay. And side effects, you want to also be familiar with these. I know that those were just mentioned, and you probably talk about those before. But things like peripheral edema, if you have a patient that has swelling in their legs, that is an issue. You should have talked about this in your hypertension section too. You may want to be cautious with your dihydropyridine calcium channel blockers. If you have someone that already has a low heart rate or is maybe elderly and we're concerned about their heart rate, the non-dihydropyridines, you have to be more careful with those. Have you talked about sick sinus syndrome at all? Okay. So just what can happen with sick sinus syndrome is as patients get older, their sinus node, which is located in the right atrium that we talked about before, does not work as well. And so they can get times where their heart rate can be very low and times where their heart rate can be very high. Fast, slow, and this increases with age. And it's important to kind of know if you saw this on someone's profile, because if you started them on something like a non-dihydropyridine calcium channel blocker, the chances that their heart rate could go low where they would be symptomatic with it could be a little bit higher in somebody that has sick sinus syndrome. So what do we do normally in those patients? If they have an indication for something like a beta blocker, or if they needed something like a calcium channel blocker and they have sick sinus syndrome, we'll often put in a pacemaker that'll help to pace their heart, and then we can use the medication because we know that their heart rate, now that they have a pacemaker, won't drop below a certain rate. And then bradycardia you also have to be cautious of. When you talk about heart failure, you probably won't talk about calcium channel blockers that often, because what do they do to the contractility of the heart? Decrease it. Yep. So they decrease the force of contraction. So in patients with heart failure where their heart isn't pumping as well, you have to be very careful, and we hardly ever will use non-dihydropyridine calcium channel blockers in those patients because of that. So when we talk about the acute coronary syndrome section, and we start talking about patients now that have a lot of damage to their heart muscle because of their acute coronary syndrome, we'll be very cautious with these non-dihydropyridine calcium channel blockers. If not, we don't use them usually at all, unless we have some other compelling reason to use them. So what are some patient education points that you guys can think of for patients that we send out on calcium channel blockers? What about if you send them out on amlodipine? What are you going to tell them to look for? Peripheral edema, swelling. Notify your physician. And then what if you have someone that you send out on a non-dihydropyridine calcium channel blocker? Their heart rate. And what will happen, say they get concerned about it and they stop it? Reflex tachycardia, and you can get rebound. So you guys got both of them. Don't stop them abruptly for the non-dihydropyridine calcium channel blockers, and to watch out for peripheral edema for those patients that you send out on the dihydropyridine calcium channel blockers. This kind of goes, I would say, that don't abruptly stop your meds is a theme that you're going to see throughout all of these lectures that we talk about ischemic heart disease. Most of the medications that we start these patients on are things that they have to be on, and things that you want to tell them if they're having some side effect that you want to make sure that they contact their doctor immediately and don't stop things. All right, and then nitrates, why do we use these? Because they decrease myocardial oxygen demand by decreasing preload, which is what? What is preload?
The amount of blood in the ventricle right before it pumps.
Yep, the amount of blood in the ventricle right before it pumps. So you can imagine if the ventricle is more distended, it's going to have to pump more, and that's going to increase myocardial oxygen demand. And then it causes arterial vasodilation, usually in higher doses. It usually affects preload before afterload, but what is afterload? The force that the heart has to pump against. So if you cause someone's arteries to be more constricted, your heart's going to have to work harder to pump that blood. It also increases myocardial oxygen supply by vasodilating those coronary arteries, and it prevents vasospasm. So for nitrates, it affects both myocardial oxygen demand and myocardial oxygen supply. Adverse effects you should have talked about already, and these are important counseling points when we start people on these. So one of the biggest side effects that people complain about with isosorbide and mononitrate and dinitrate is the headaches that they will get with those. If we feel like there's a compelling reason for them to be on, we'll try to lower the dose down and see if they'll be able to tolerate it. Or we'll have them take Tylenol if they're able to. But this is probably the rate limiting step for a lot of those preparations that we'll see. It's another counseling point too if you're going to have someone take sublingual nitroglycerin, to make sure that's one of the reasons that we tell them to sit down, is because they may get a headache from that immediate effect that they get from the sublingual nitroglycerin, as well as it can cause their blood pressure to go down, and so that's why we tell them to sit down. We don't want them to be standing up and put that under their tongue and then have their blood pressure drop and have them get a headache. So as far as education points that you'll want to remember with the nitrates, when we're talking about especially acute coronary syndromes or stable angina, when we go through those, we tell them to keep them with them at all times. Usually what I'll say to the patients is this wards off evil spirits because if they have their sublingual nitroglycerin, hopefully they don't have repeat episodes of chest pain, but you definitely want to make sure with variant angina or with stable angina or with acute coronary syndromes, they have no idea when some of these things are going to occur, that they have the immediate sublingual nitroglycerin that they can have with them for their acute attacks. Sit down, and then as you just heard about, if they get that tingling sensation under their tongue from the vasodilation, they know that the medicine's working. A lot of times what happens with these patients, not necessarily as much with the variant angina patients, but the stable angina or acute coronary syndrome patients, is that they won't need their sublingual nitroglycerin for a year or 2 years. It's been sitting there in the bottle, and it's usually turned into a powder at that point. So you can tell them, like, if you need this 6 months or a year from now and you put it under your tongue and you don't get that burning sensation, it may be that the nitroglycerin is too old. And then replace it when it's expired. So one of the things that you may see on some places is that you have to renew this every 6 months. The tablet formulation was changed, so the date that's stamped on the side of the bottle, like an egg carton, is the date that they actually need to need to make sure that they renew their nitroglycerin for, so that they have it with them for those acute attacks if they need it. And then to kind of tie in your lecture that you just had, for the long-acting preparations, so this is how to prophylactically prevent that vasospasm or the variant Prismental's angina. They need to have a nitrate-free interval. So one of the ways that we'll do this with the dinitrate or mononitrate formulations is to really pay attention to when we're telling the patients to take those. So for the dinitrate, we'll tell them to take it at 6, 12, and 6, so they have that 12-hour free interval. And for the mononitrate, we'll tell them to take it at 9 a.m. and 5 p.m. So one of the things, if you look back to your slides that you just saw, we sometimes, if people have really difficult to control chest pain or angina, we'll have them take the mononitrate formulation, which you usually think of once a day, but we can even have them dose it twice a day as long as they take it at 9 and 5 and have that 10 to 12 hour nitrate-free interval. The nitroglycerin patches, we have them put it on at bedtime and remove in the morning. But as far as if we were to take kind of a list of these and what we commonly see, these two we will use over the patches in a lot of patients because the patches are more expensive. And the other thing is that usually we have a lot of patients that put the nitroglycerin patch on and then they forget to take it off in the morning. And so for convenience sake, it's a little bit easier to have them take these tablets. Abrupt discontinuation, again, common theme here, can cause rebound vasospasm. So you want to be very, very careful with that. And then you don't see the paste up here. Why is that? Or ointment. Why do you think that is? What's that? It's difficult to use. So have any of you ever dispensed nitroglycerin ointment or paste? There's a piece of paper, you got to measure it out on there, how much it is, and you got to put it on. They've got to use it at the 6, 12, and 6 intervals, so they've got to take the piece of paper off, and then they end up having to wipe it off and put their new one on. So typically, we only see this used a lot of times in the hospital, and then that isn't even used that frequently. It's also fairly expensive. It's been on shortage, so the ointment is not something that we commonly see. I have like maybe 2 patients in the last 10 years that I've seen on the ointment or the paste. Sometimes we'll use it in the hospital because you can apply it and wipe it off, but it's only used usually for those acute situations. It's not something that we typically will send patients home on. All right, so here's a case. MB is a 43-year-old white female admitted to the emergency department with complaints of 3 episodes of crushing chest pain in the past 24 hours while she's just sitting there. She's got hypertension. She smokes 1 pack per day for 20 years. She's on hydrochlorothiazide at home. Got a blood pressure of 146/62 with a heart rate of 78. We get an EKG. It shows no ST elevation. Remember we talked about earlier, that's one of the first things that we want to make sure that we don't see. Her troponin, what is troponin? Anybody know? We haven't talked about it yet. It's an enzyme that if there's damage to your heart muscle is released. So you can imagine if you have either a plaque in there that's blocking that coronary artery, or you have vasospasm, which you have with variant Prismental's angina where you have decreased blood flow. One of the ways that we know you have damage to your heart muscle is by measuring something in an enzyme in your blood called troponin. And if this is elevated, it does mean that some of those cardiac myocytes, that there's damage to those. They get a left heart cath that shows no coronary artery disease, so we don't see that there's any blockages from plaque in their coronary arteries. Which of the following would you recommend? Stop hydrochlorothiazide and start carvedilol? So what do you think's going on with MB at this point? What does it sound like? Unstable angina, why do you say that?
Because she's saying she's having these episodes of crushing chest pain.
Okay.
So it's probably like a partial blockage somewhere. Obviously, we have a left coronary.
Okay, so she's saying unstable angina because she's having crushing episodes of chest pain. So what, with unstable angina, if you were going to do a left heart cath, what would you be looking for? You guys remember from your pre-lectures? A plaque in the coronary artery. So if there's a left heart cath and there's no coronary artery disease, that means there's no plaque in the coronary arteries. But she's still having this chest pain. What's the other thing that it's happening at rest while she's just sitting there? It's vasospasm. So this is what we see. It's very confusing, and why I wanted to make sure we spent a little time in this case. So for the variant Prismental's angina patients, a lot of times they will present sometimes even like an ST elevation MI where we'll have ST elevation on the EKG. They can have troponins that are elevated because as that artery spasm is enclosed down, no blood flow can get through there. But when we go to do a heart cath, we see no blockages or plaques in their coronary arteries. So they can present often, sometimes even just like an ST elevation MI. But when we do the heart cath, there's no blockages in there. So if we say that this is variant Prismental's angina, it's occurring at rest, so that takes stable angina off the table. And then we say that we do a left heart cath and we say no blockages in their coronary arteries. Variant Prismental's angina is the diagnosis that we would usually come up with. So looking at that, I want to go through and kind of see. How many would say A, stop hydrochlorothiazide and start carvedilol? No. Continue hydrochlorothiazide and start metoprolol, 75 milligrams by mouth twice a day. No. Stop hydrochlorothiazide and start amlodipine 5 milligrams by mouth daily. Does anybody want to do that? Oh. Continue the hydrochlorothiazide and start amlodipine 5 milligrams a day. Okay, so majority of you raised your hand. Some of you didn't answer. But that's okay. So if someone raised their hand, can they tell me why they picked D? Go ahead.
So you don't want to stop hydrochlorothiazide because it's not contributing and it might be helping her blood pressure at all.
Okay.
That's why I said instead of stopping it, just continue it. And you pick amlodipine over the metoprolol or the carvedilol because a calcium channel blocker is indicated, a beta blocker is not.
Okay, yep. So from our previous discussion, beta blockers we try to avoid in these patients if they have pure variant Prismental's angina because it can actually maybe not be helpful or it could actually be harmful. And I would say C or D would be probably acceptable answers, and this is where for discussion up here I would not give you something that's this close in an exam form because it's probably not fair. And right now you could say maybe stop the hydrochlorothiazide and start amlodipine at 5, and then depending on what happens with this patient's blood pressure, you could potentially even go up on the amlodipine. Or it wouldn't be wrong to continue the hydrochlorothiazide, start the amlodipine 5 milligrams, and then see how her symptoms are. And that may be okay to get you at a blood pressure where you want it and you're able to control her symptoms. So C or D would probably be acceptable answers with the thought that you follow up on the patient to see how she's doing. Is her chest pain episodes decreased? What else would you probably send her home on? Okay. Sublingual, yep, aspirin and sublingual nitroglycerin. Why sublingual nitroglycerin? For the acute attacks, right? And then that way you're able to monitor and see is she using sublingual nitroglycerin. If she is, then maybe stopping the hydrochlorothiazide and going up on that amlodipine would be an option. So you want her to have something to help control it for prophylactic, like the amlodipine, and then you want to make sure she has something for her acute attacks like the sublingual nitroglycerin. Does that make sense? So the points that I want to make sure for this case is with variant Prismental's angina, if you have vasospasm long enough and the patient's at home and doesn't know what's going on, you could have some increase in your cardiac enzymes and some damage to the heart muscle. And usually you'll find that there's no coronary artery disease on the heart cath. There are some tricky patients, though, that will have coronary artery disease and have variant Prismental's angina. But you want to make sure that you exclude that there's coronary artery disease. That's one of the first things that you want to do in these patients. All right, so if we move on and compare that to patients with stable angina, their supply is sufficient at rest, so they do have some blood flow through that coronary artery, but when they start to exercise or exert themselves, that's when you start to have chest pain because there's that imbalance of oxygen supply and demand. And it can be due to the blockage as well as some vasoconstriction of that coronary artery. When we treat these patients, if you think about that progression, what we're trying to do is prevent the progression to acute coronary syndromes and cardiac death, prevent any of those acute attacks that they're having, and minimize the adverse effects of the medications that we're going to be treating them with. You should have already talked about some of these risk factors that we'll want to try and modify to prevent the progression of that stable angina, so smoking cessation, treating their hyperlipidemia, hypertension, making sure that they're exercising. Those are all things that go hand in hand with preventing the progression of their stable angina. And then this is kind of a good mnemonic to remember is A, B, C, D, E. So we'll go through these. You'll want to put them on aspirin and an anti-anginal therapy. You'll use beta blockers and make sure that we have their blood pressure controlled, and a lot of the blood pressure management you had talked about previously. Get them to stop smoking, control their cholesterol, control their diet and diabetes, and then education and exercise. So for aspirin, normally we'll do 81 milligrams by mouth daily. It says 72 to 165 in the guidelines because 75 is the dose that's available in Europe. Although I would say every year, usually what happens to me right before I give my lectures is articles start coming out about doses of things that may change. So there's been about 3 articles in the last 2 weeks questioning what the dose of aspirin actually is for some of these patients. But for now, 81 milligrams by mouth daily is what I want you to remember. I bring it up because somebody will say, I just saw an article that says maybe 325. So you might see some whisperings of that right now. The guidelines, this is what we recommend currently. And it should be used in all stable angina patients unless contraindicated. So what would be some contraindications to aspirin? What's that? What about an allergy? What's that? The Reye syndrome? Okay. That's questionable, but yeah, it's something that you would want to know about. We actually just had a patient that had Reye syndrome, and we didn't find too much data because it happened when they were a child to use it as an adult, but something that you would want to ask about and look at further. What else? Anaphylaxis, right? So the point here is a lot of people have aspirin allergies, and you might hear that they get some stomach upset or GI upset. That's much different than somebody that has throat swelling or tongue swelling from aspirin. So you want to make sure that you don't just say aspirin allergy and move on as a pharmacist. You've got to find out a little bit more about that history, when they took it, what happened before you say that they can't take it. The alternative to that is clopidogrel 75 milligrams by mouth daily. There are 2 other antiplatelets that we'll talk about when we talk about acute coronary syndromes. Those are ticagrelor and prasugrel. We do not use those in ischemic heart disease. They have not been studied in those patient populations, and their bleeding risk is much higher, and so clopidogrel or aspirin are the 2 that we use in patients with stable angina. As far as beta blockers, we already talked about, they decrease myocardial oxygen demand, similar to those non-dihydropyridine calcium channel blockers by blocking conduction through the AV node and slowing their heart rate. They decrease contractility, and they help prevent, they're cardioprotective, and they prevent arrhythmias. And you'll want to remember those different properties that you talked about in your previous lecture. So lipid solubility, what's their half-life, their volume of distribution. So taking all of those into account, and then what receptors they look at or work at. So just take, I'm going to give you a minute to do this because hopefully you should be able to do this pretty quickly. Go through each one of these and say whether they're beta 1 selective, beta 2 selective, or alpha. And then I want you, in a second I'm going to ask why would you choose one over the other. This is going to be something that you're going to commonly see, so hopefully this should be old hat for you at this point. Okay. So hopefully you were able to get most of these. So we've got drugs that are beta 1 selective, so mostly going to decrease the heart rate, like atenolol and metoprolol and bisoprolol. And then you've got ones that are not specific for beta 1 receptors and mostly going to be beta 1 and beta 2. And so those are going to be ones like carvedilol and labetalol. So if we take a patient that has a high blood pressure and a low heart rate, which one of these would we choose? Carvedilol. Because it's going to affect beta 1 receptors and slow down the heart rate, and it's going to cause vasodilation. So it's going to help to lower our blood pressure, maybe not have as much effect on our heart rate. If we have somebody that has a higher heart rate and their blood pressure is borderline or a little bit lower, which ones would we choose? A beta 1 selective, like metoprolol or bisoprolol. So remembering going forward when we get patient cases and we're just trying to decide between different beta blockers, we've got to keep in mind what their heart rate and their blood pressure is when we're deciding one beta blocker over another. The other thing that we have to think about is the side effect profile, which we'll talk about in just a second, because those selectivity of those receptors will drive some of the side effects that we also see. The other thing that you talked about just a few minutes ago was that some of these are preferred for patients with heart failure. So our ones that are preferred for heart failure are going to, those people with a low ejection fraction are going to be carvedilol, metoprolol XL, and bisoprolol. And so here we have initial doses and then the doses that we would titrate to. So one of the differences here in comparison to where you talked about blood pressure before, when you're trying to control someone's blood pressure, you have a target blood pressure that you're going to try and get to, right? For these patients, if they have heart failure, we'll try and push to these maximum doses, even if their blood pressure is below the goal that we would want, as long as the patient's not symptomatic. So does that make sense? So we watch them and we'll say, okay, our target dose for metoprolol XL in a patient with heart failure is 200 milligrams a day. And we'll try and push to that dose, and we'll watch their heart rate and blood pressure and make sure that they're not symptomatic and keep going. Whereas for your blood pressure goals, when you talked to before, you had a certain number that you were trying to get those doses to, and when you got to that, you would stop. For the patients with stable angina or for patients with acute coronary syndrome, we also look at their heart rate, and this is our target heart rate for those patients, 50 to 60 beats per minute. Why do you think we want such a low heart rate? What's that? Lowers demand. Yep. So for those patients, we'll look at their blood pressure, we'll look at their heart rate, and we try to target for those patients with stable angina and those patients with acute coronary syndrome to a heart rate goal of 50 to 60 beats per minute. I would circle that, so you probably see that again. And the blood pressure really depends on the comorbidities that they have. As far as adverse effects, you should have already gone through these, but some of the ones that come up commonly are patients that have bronchospasm or patients that have COPD, chronic obstructive pulmonary disease, that are on inhalers. We have to be careful with which type of beta blockers. Non-selective, and what's the example for that? Carvedilol, yep. Because for those patients, you can affect the beta-2 receptors. It can worsen bronchospasm. It's not to say that you can't use those, but you've got to look at your patient and make sure that they're not becoming more symptomatic if you do end up starting one of those medications. If they do, what would you do? So you had them on carvedilol and you've increased the dose, and now they tell you that they're having to use their rescue inhaler more often. Switch to metoprolol. Okay, very good. So for bronchospastic disease, we normally will stick with beta-1 selective agents. It is a relative contraindication, so I don't want you to think that we can't use beta blockers at all in those patients, and it sounds like you guys do understand that point. We talked about those patients with sick sinus syndrome before, or that have difficulty with the function of their SA node, and you have to be careful in those patients with beta blockers just like you would with the non-dihydropyridine calcium channel blockers. And then how quickly we increase the beta blockers if a patient's in heart failure or they're not pumping blood as well, and they're acutely decompensated, being careful about increasing the beta blockers in those patients. As far as patient education points, kind of a common theme here, we do not stop these abruptly because it can lead to angina, it can lead to a heart attack, they can get reflex tachycardia. We want to make sure that they're consistent with their dose and the time that they take it, and probably one of the most important points for these patients is that when you start beta blockers, you can kind of feel sluggish to begin with. They might feel a little bit tired, so to make sure that they understand that and they don't stop the medication, that it'll take a little time for their body to adjust to it. And then lastly, nitrates for stable angina. We do use these for acute attacks of their chest pain. We say 1 sublingual nitroglycerin every 5 minutes for a maximum of 3 doses. which is a little bit different than when we talk about for acute coronary syndrome, where we'll say 1 dose, and if your chest pain's getting worse or it's not getting better, then we tell them to call 911, especially if they've had a recent heart attack, because it could be a sign of another recent heart attack. So one of the questions I'll commonly get is, since this is a progression, how do they know they're not having an acute coronary syndrome? And should I wait for 3 doses? If there's any question where the stories that they're giving you is this is getting worse, it's not getting better, my chest pain isn't responding, you'd be safer to call, they'd be safer to call 911 than continue to take 2 more doses. Because if you remember, this is a progression. So they could have something where it's now something that it's been their typical chronic stable angina for a long time, and now they're having an acute attack. They can always call 911 to be on the safer side. But you'll have patients where they tell you, when I do this activity, I know that I'm going to have chest pain. And so then in those patients, if it's something that's predictable and you've ruled out anything bad that's happening with them, they can use up to 3 of those. And if it's not getting better, then they can call 911. If you can see the difference between those. Yes?
You talked about preventative nitrates, and you said that if they know the activity that they're engaging, pause,
Yep. You can tell them, just like you talked about before, 10 minutes before, use the sublingual nitroglycerin. If they forget and then they have chest pain, they can use it this way as an acute attack. But if there's any question as to, is this something where now I have, where I'm getting progression of my disease or something really acute may be going on, they can always call 911 if they need to. So some of this, I will be honest with you, for patients it's scary. They don't know whether they're having a heart attack or something's going on. So we will have patients with chronic stable angina that will come in, and we end up finding out, you know, this is just the way that your disease is, and give them some of those recommendations like you're saying, where if I'm going to do X activity, I'll just take the nitroglycerin before to try and prevent it from occurring rather than waiting for it to occur. All right, so I'm going to pause here. I know hopefully you guys have seen this diagram already. I want you to kind of think through for each of these medications where nitrates would work, where the dihydropyridine calcium channel blockers would work, where the non-dihydropyridine calcium channel blockers would work, and where beta blockers will work. And I'm going to give you 2 minutes to do this. So for each of these, so for someone has increased resistance from your pre-class activities, they'll have decreased supply, decreased oxygen to the myocardium, and resulting in chest pain. So which medications will help to treat each one of these different scenarios? Okay, you ready? So if we talk about increased resistance, we would want to have drugs that do what? Vasodilation. So what ones would you be able to use for these patients if we're trying to treat the increased vasoconstriction or increased resistance? You want to say? Calcium channel blockers, yeah, you could either use non-dihydropyridine or dihydropyridine and nitrates. What about if you have decreased oxygen carrying capacity? Mostly this is going to be give them blood if they're low. You might be able to use nitrates, someone said, to vasodilate them, but it's not really going to affect the oxygen carrying capacity. So there's not really too many drugs that we can do this. This is usually your patients with anemia that have a low blood count because that's what carries oxygen to the tissues. Heart rate is going to be your beta blockers and your non-dihydropyridine calcium channel blockers, not your dihydropyridine calcium channel blockers. What about increased preload? What's going to decrease that? Yep, nitrates. What about if you have increased force of contraction and you want to kind of slow that down? Beta blockers and non-DHPs. Increased wall tension. So if you have something where your ventricle is going to be stretched and going to be fluid overloaded, how are you going to decrease that? Nitrates? Okay. So as you're going through your patients, you want to make sure you understand, is it an oxygen supply issue? Is it an oxygen demand issue? And then you want to know which medications affect each one of these. I will post these slides so you guys don't have to worry about if you miss something on them. Go ahead. Not necessarily, because in order to affect preload, what is that mostly going to be relying on? Of what? Veins or arteries? The venous system, yeah. So mostly the dihydropyridine, non-dihydropyridine calcium channel blockers are going to affect more your arterial vasodilation or afterload. Yep, it's a good question. Okay, so the steps for stable angina, if we kind of put this all together, you're going to want to do risk factor modification, so you're going to use your moderate to high intensity statins, which you guys already should be very, very familiar with. Aspirin 81 milligrams, unless they're allergic, and then you can use clopidogrel. You're going to want to give them sublingual nitroglycerin. As you had talked about, there is a nitroglycerin spray. Very few patients are on this because it's much, much more expensive than the sublingual nitroglycerin, and so usually it's only due to patient preference that they're on the spray. So usually what we'll do for the prevention of acute attacks, or if instructed for stable angina, we'll use the sublingual nitroglycerin. Beta blockers to control their heart rate with a goal of 50 to 60. And then if there's a contraindication to beta blockers, then we'll use our non-dihydropyridine calcium channel blockers or a long-acting nitrate. Like, what would those be? Yep, isosorbide mononitrate is usually what we'll use. Sometimes we may use dinitrate, but that has to be dosed more frequently. If they don't respond to all that, we'll use a combination of beta blockers, calcium channel blockers, and a long-acting nitrate. If they have some of those compelling indications that you talked about in your hypertension section for ACE inhibitors, we will add on an ACE or ARB, and then we consider ranolazine after we've done all of these other therapies. You guys talk about ranolazine already? Or Ranexa? How much does it cost? What's a lot? That's a little bit much, but about $350, give or take. And often this requires a prior authorization, which I know for those of you that work in retail, it's a pain. And so you have to prove that they've been on all of these other therapies, and then we're trying to add on ranolazine if we even try to get a prior authorization done for that. And then opening up the coronary arteries is the last way to treat the stable angina if we need to. So again, ranolazine is used only for those patients where we've tried all of these other therapies and they have failed. Yep.
If you're using a combination of beta blockers and calcium channel blockers, for hypertension, they said that you want to choose a DHP in that case because it's too similar to have a non-DHP. Is it the same here?
Usually it is, yes. The only time, and I hate to bring up caveats to everything, but you're going to probably encounter those, is if we have a patient on a beta blocker where we've titrated it up and their heart rate is still difficult to control where we want it to, we may use a non-dihydropyridine calcium channel blocker. But what I would say is those are always ones where I'd pause if I saw the two together and kind of try and figure out what's going on first, rather than assume that it's the correct thing for them to be on. All right. So for ranolazine, I guess the big take-home points are 500 milligrams twice a day is usually what we start with. You can increase to 100 milligrams twice a day. It is metabolized via CYP3A, so there's and 2D6. So some of those drug interactions that we are so fond of that we have to be careful of with things like simvastatin, diltiazem, verapamil, and then really adverse effect-wise, it's pretty minimal. The only other time that we'll see ranolazine if we don't used is if someone's heart rate and blood pressure is an issue and we can't add on calcium channel blockers or long-acting nitrates because of that. We will see ranolazine used in those patients where their heart rate and their blood pressure is a rate-limiting step for the addition of those other medications. So we'll kind of look over a case in a little while where you'll see that we haven't added on those other therapies and then ranolazine may be an appropriate choice, mostly because their heart rate and blood pressure are a limitation. The QT interval prolongation, how many, have you guys talked about this with any medications yet? Some? Okay. The take-home point with ranolazine is you can see some QT prolongation with this. It will come up as a drug interaction that you'll see. Usually what we'll tell the patients is we need to look at, see what other medications they're on and what their baseline QT is to determine whether this is something that can be continued or not. The difficult part is, as an outpatient pharmacist getting this prescription, you probably don't know what the story or what the situation is with the patient because you don't have that information immediately available to you. So I don't think it's something that's wrong for you to check on with the cardiologist or whoever prescribed the medication. But it's not uncommon for us to prescribe this in patients. We just need to make sure that we're monitoring for this QT prolongation. It's not probably one of the drugs that we see that is most profound, but it is something that you guys may see come up and something that you'd want to check on. This slide is something that kind of puts together, because some people want algorithms versus lists of medications, and so this slide is exactly what I just went through. It's just in a different form. So if some of you work better with algorithms versus lists, it's both the same information. I just wanted to present it in a little bit different way. So if this helps you more to look at it this way, it's exactly what we just went through in a list form. And then non-pharmacologic therapies for stable angina really are to open up that artery if we need to. So the two ways that we can do this are via a heart cath. We do what's called a percutaneous coronary intervention, and I'm going to show you what that briefly is, and we'll spend more time talking about that in the acute coronary syndrome lecture, or coronary artery bypass graft surgery. So for PCI or cardiac cath, there's labs in the hospital that we'll bring patients to, and we open up their artery. It's not as invasive as cutting open their chest and doing heart surgery on them, and they'll use contrast dye to be able to inject into the coronary artery and tell where there's a blockage. They'll do different types of percutaneous coronary interventions or procedures in the cath lab. They'll first look to see what the blockages in the arteries are, and then they can either balloon it open. They can do an atherectomy, which is like what we do to open up our sewers and our sewer system. So there's a little wire with a razor on the end of it, and it'll basically shave off of the plaque out of the inside of the coronary arteries, or we can put a stent in. So I do much better with pictures than I do with words. So if you look at this coronary artery, you've got the plaque. And what will end up happening during one of these PCIs or cath procedures is there's a balloon, and on the outside of the balloon there's a stent, and they'll blow open the balloon and they'll push back that plaque and they'll leave the stent in the coronary artery, and now the blood flow can get through here. So that's one of the ways that we can open up the artery and treat patients with stable angina. Another way that we can do it is through a coronary artery bypass graft surgery. We don't do these for everybody because they're more invasive than bringing patients to the cath lab. We have to open their chest, and it's a big surgery that these patients have. So if they have left main disease, we talked about that in the beginning, or if they have multiple vessels that have blockages in them, we may do an open heart surgery procedure. And basically what it does is it bypasses the place where there's a blockage. So if we look at this patient, they'll take either a vein out of your leg, or they'll use an artery that comes down the front of your chest, and they'll basically attach it to your aorta, and then this is where the plaque is. They'll basically bypass where that blockage is, so the blood flow can go down either the vein or down the artery and bypass where those blockages are. So now we're just saying the medications aren't working as well, so we're going to actually bypass where those blockages are or open them up to help improve that blood flow. So if we go back to AJ, who presents to his primary care physician, what would you like to do to optimize the treatment of AJ's angina? We go back to what he was on before. What's missing from his medical regimen? Short-acting nitrate like sublingual nitroglycerin. What else? Aspirin 81 milligrams a day, correct? What else? Is the hydrochlorothiazide the best option for him now? Assuming that we are saying this is stable angina? You could do amlodipine because his blood pressure is high. His heart rate's in the 80s, though. Probably start with a beta blocker. Which beta blocker would you use? Metoprolol. Someone may say carvedilol too, potentially because his blood pressure is so high, so you may not be able to get your dose high enough to be able to control your blood pressure as well as your heart rate. So I don't think there's any one right or wrong answer in this particular patient as far as carvedilol and metoprolol, as long as we're following up and making sure that we're achieving the goals that we need to. Does anybody have any questions? So is there anything wrong with the hydrochlorothiazide? If we look at what's going to be most beneficial for him if he does have stable angina, this is not going to help control the heart rate. It's not going to help decrease oxygen supply or increase oxygen supply or decrease oxygen demand. So this is where we start talking about if we have compelling indications for something. The hydrochlorothiazide may limit the amount of those other medications that we're able to give to be able to help control his heart rate and achieve what we're trying to for a stable angina, if that makes sense. Now, if his blood pressure was very high and we were able to control his heart rate, leaving this on may not be such a bad idea. But we haven't started any of the medications that we have just talked about, and so that might be a rate limiting step for that. All right, DB is a 46-year-old white female. She presents to her primary care physician because her chest pain is not controlled. She feels like she needs something that lasts longer than her sublingual nitroglycerin when she goes to hip hop. She's trying to eat right and go to hip hop 3 times a week. Her past medical history is significant for coronary artery disease and hyperlipidemia. She does not smoke or drink. Here's her current medication profile with her blood pressure and heart rate. So what changes would you like to make to DB's medication regimen to help control her angina? So what are some things you notice about the vital signs here? High heart rate, lower blood pressure. So what are you going to be able to do to help control her heart rate? What would be one of the first line regimens that we talked about? If you think about those list of medications we went through. Did someone say a non-DHP? Okay. What would we do before a non-DHP? You do, yep, you could actually go up on this metoprolol, right? So maybe go up to 50 Q12 and see if her blood pressure will tolerate it. If you were going to do a non-DHP at this point, you probably wouldn't want to do the non-DHP and metoprolol, but the beta blocker is preferred first over the non-dihydropyridine calcium channel blocker. What other medication could you, what about isosorbide mononitrate? Would you be able to do that in this patient? If her blood pressure could handle it, so that might be something you could try. And then what other drug did we talk about that might not really have an effect on the heart rate or blood pressure? Yep, ranolazine. So I would say first thing would be to try and increase that metoprolol to see if you can get her heart rate down and that her blood pressure will tolerate it. Maybe you could consider isosorbide mononitrate, but the blood pressures are a little bit of an issue here and the heart rate's still high. And if they don't tolerate any of those, you could try something like ranolazine or Ranexa. And then if we compare it to the situation here, now we have maybe a little bit lower, more blood pressure room to work with, and our heart rate's at our goal, right? 50 to 60. So in this patient, you could try what in comparison to the vital signs that you were given before? What would be your options now? Would you go up on the metoprolol? Probably not, because you've got your heart rate pretty much where you want it to in that 50 to 60 range. What about a non-dihydropyridine calcium channel blocker? It'll drop the heart rate too. What about a dihydropyridine calcium channel blocker? Maybe, right? You could do something like a low dose of amlodipine. You could potentially do a long-acting nitrate in this patient. And you'd probably try all of those before you'd put them on a $300 drug like Ranexa. So do you see the difference between those two patients in your thought process and how you go through them? Okay. All right. Any questions? All right. Thanks, guys.